Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. A virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 258 of our pharmacotherapy series, which majors in sexually transmitted diseases. The first question reads, NOW, a 27-year-old woman in her 19th week of gestation, has a positive VDRL and FTAABS. How should NOW be managed? How would management be altered in the face of penicillin allergy? Although pregnancy may be associated with false positive non-treponema tests, the presence of both a positive treponema test, e.g., FTAABS, and a non-treponema test, e.g., RPR, virtually excludes a false positive reaction. The next step is to determine whether NOW already has been treated adequately. If she has previously received adequate treatment and follow-up and shows no evidence of persistence or recurrence of syphilis, then she requires no further therapy. Pregnancy has no known effect on the clinical course of syphilis. However, her infant should be observed carefully. If NOW has not been treated previously for syphilis, then she should be treated with penicillin in the same doses recommended for non-pregnant women. Some experts recommend a second dose 1 week later of 2.4 million units of benzathine penicillin. The goal of therapy should be to treat the mother with syphilis as soon as possible. Syphilis transmission can occur transplacentally as early as 9 to 10 weeks gestation via direct contact with lesions in the birth canal. If the mother is left untreated, 70% to 100% of fetuses born to mothers with primary or 40% with secondary syphilis may be aborted, stillborn, or born with congenital syphilis. There is no completely satisfactory alternative for the pregnant woman with an accelerated allergic reaction to penicillin. Tetracycline, as well as doxycycline, should be avoided during pregnancy, especially during the second or third trimester, because of tetracycline's known effects on the fetus, tooth staining and inhibition of bone growth. Erythromycin has been used to treat pregnant patients with syphilis. However, the transplacental transfer rate of erythromycin is inadequate, potentially explaining the increased rate of aborted or stillborn infants in erythromycin-treated patients. Erythromycin and azithromycin are not recommended as alternative therapy for syphilis during pregnancy. A woman with a history of allergy to penicillin should be skin tested. If allergy is confirmed, she should be desensitized and treated with penicillin. It is possible that the newer cephalosporins may ultimately prove to be acceptable alternatives to penicillin G in the pregnant woman with syphilis, who is allergic to penicillin, but there is sufficient evidence for the CDC to recommend their use. Adequate treatment with penicillin can prevent up to 98% of fetal infections. Serologic titers, at a minimum, should be followed up at 28 to 32 weeks gestation and at delivery. Monthly serologic titers may be considered in women at high risk for reinfection or those in geographical areas of high syphilis rates. Thereafter, she should be followed up as any other patient with syphilis. The next question reads, NOW was treated with an IM injection of 2.4 million units of benzathine penicillin G. 6 hours later, she complained of diffuse myalgias, chills, headache, and an exacerbation of her rash. She was tachypneic, but normotensive. What is this reaction? How should NOW be managed? NOW has developed the Jarisch-Herxheimer reaction, abbreviated as JHR, a usually benign, self-limited complication of antitroponmal antibiotic therapy that develops within hours after treatment of early syphilis. The cause of Jarisch-Herxheimer reaction is not well understood, but it is probably related to the release of cytokines. Clinical manifestations include fever, chills, myalgias, headache, tachycardia, and hypotension. The pathogenesis of the syndrome is uncertain, but the reaction should not be interpreted as an allergic reaction to penicillin. It typically begins within the first 24 hours after antibiotic administration and normally subsides spontaneously, generally subsiding even while antibiotics are continued. Notably, Jarisch-Herxheimer reaction can occur after administration of many antimicrobials and is not exclusive to penicillins, nor is it exclusive to syphilis treatment, occurring in other spiritual diseases, such as Lyme disease and relapsing fever. Usually self-limiting in non-pregnant patients, the primary risk of this reaction in pregnant women is miscarriage, premature labor, or fetal distress. Pregnant women should seek medical attention if contractions or a change in fetal movements are noted. Close monitoring of Jarisch-Herxheimer reaction should be observed for patients with ophthalmic or neurologic syphilis. For these patients, prednisolone 10 to 20 mg 3 times a day for 3 days given 24 hours before syphilis treatment may prevent fever, but it will not control local inflammation. Tumor necrosis factor alpha has been demonstrated to have some success in the prevention of Jarisch-Herxheimer reaction in Spirochetti disease. Although there is no proven effective preventive therapy, some experts still recommend antipyretics, hydration, and patient education. Antibiotic therapy should not be discontinued. The next question reads, how should NOW's baby be treated if a diagnosis of congenital syphilis is confirmed? Infants born to mothers who have been treated for syphilis during pregnancy should be carefully examined at birth with a quantitative non-troponmal serologic test. If tests are reactive, the infant should be followed and have serologic testing every 2 to 3 months until non-troponmal tests are non-reactive. Newborn serology is difficult to interpret because of transplacental transfer of non-troponmal and troponmal immunoglobulin G to the infant. Treatment decisions are largely based on evidence of syphilis in the mother, adequacy of maternal treatment, comparison of maternal and neonatal non-troponmal serology, and/or presence of clinical or laboratory evidence of syphilis in the neonate. In addition, infants should be treated at birth, even if they are asymptomatic, when maternal treatment is unknown or inadequate, or when infant follow-up cannot be guaranteed. In most cases, a CSF examination should be performed before treatment is begun to rule out neurosyphilis. The next question reads, ATG, a 31-year-old uncircumcised sexually active male, presents to the STD clinic with complaints of tender lesions on the penis and inguinal regions. He noticed the penile lesions on the external surface of the prepuce, that is the foreskin, 2 days before his visit. The lesions were sharply demarcated but were not indurated. The base of the penile ulcer was covered by a yellow-gray purulent exudate. Right inguinal adenitis was present and extremely painful on palpation. A dark field examination of the purulent exudate was negative. Gram stain revealed a mixture of gram-positive and gram-negative flora. ATG claims to have an allergy to penicillin, but no other drug allergies are reported. What is the natural course of chancroid? Does ATG have signs or symptoms consistent with chancroid? What diagnostic procedures are necessary? Uncircumcised men, as well as circumcised men, may have an increased risk of chancroid infection and may not respond to therapy. In fact, evidence suggests circumcision is protective against nearly all STDs, including HIV, as well as protecting women against Trichomonas vaginalis and bacterial vaginosis. A painful genital ulcer appears 3 to 10 days after exposure and begins as a tender, red papule that becomes pustular and ulcerates within 2 days. Chancroid can be suspected if all of the following criteria are met. 1. One or more painful genital ulcers present. 2. Regional lymphadenopathy. 3. No evidence of Treponema pallidum by dark field examination, and 4. A negative HSV PCR test or HSV culture. As illustrated by ATG, the ulcer may be covered by a grayish or yellow exudate. A gram stain can be misleading because of the polymicrobic nature of the ulcer and culture and because isolation of Haemophilus ducreyi is difficult, requiring specialized specimen collection and growth media. The next question reads, how should ATG's chancroid be treated? Most strains of Haemophilus ducreyi produce a TEM-type beta-lactamus, and many strains are resistant to the antimicrobials that traditionally were used to treat chancroid, such as sulfonamides and tetracycline. Currently recommended CDC treatment regimens include azithromycin 1 gram orally for 1 dose, ceftriaxone 250 mg IM once, ciprofloxacin 500 mg orally twice a day for 3 days, or erythromycin base 500 mg orally 3 times a day for 7 days. Ciprofloxacin is contraindicated in pregnant and lactating women. Because ATG has a history of penicillin hypersensitivity, azithromycin as a single oral dose is a preferred treatment regimen. Treatment may not be as effective for patients who are co-infected with HIV or who are uncircumcised, therefore HIV testing should occur at the time of chancroid diagnosis and if negative, should be repeated 3 months after the diagnosis. Follow-up should occur 3 to 7 days after treatment is initiated. Depending on the size of the ulcer, the time required until complete recovery will vary. Larger ulcers may require longer than 2 weeks. Because ATG is also sexually active, his sexual partner should be evaluated and treated if they had contact during the 10 days prior to the onset of symptoms. The next question reads, HHH is a 24-year-old, sexually active woman with a 1-week history of moderate vaginal discharge that has a fishy odor, most notable after coitus. She has no complaints of vaginal pruritus or burning. On examination, the discharge appears thin, white, homogeneous, and notably malodorous. A wet mount of the vaginal secretion revealed few leukocytes and numerous clue cells. The vaginal pH was 4.8, and a characteristic fishy odor was noted when the discharge was mixed with 10% potassium hydroxide. Does HHH have signs and symptoms consistent with bacterial vaginosis? What diagnostic tests are required? HHH's signs and symptoms are typical of bacterial vaginosis. The clinical diagnosis can be confirmed by a vaginal gram stain that shows overgrowth of the vagina with Gardnerella vaginalis and other organisms as noted earlier. A 10% potassium hydroxide solution mixed with the vaginal secretions yields a transient fishy odor because of the increased production of biogenic diamonds, referred to as a positive amine test. A wet preparation of the specimen reveals clue cells, exfoliated vaginal epithelial cells sometimes with adherent coccobacillary pathogens, vaginal pH greater than 4.5, and the characteristic potassium hydroxide whiff test. If there are many white cells, other infections, e.g., Trichomonas vaginalis, should be suspected. Self-diagnosis is correct only about 3% to 4% of the time because most women attribute symptoms to poor hygiene. The next question reads, how should HHH be treated? Non-pregnant women with symptomatic disease require treatment. CDC recommended regimens include oral metronidazole 500 or 400 mg twice a day for 7 days, metronidazole gel 0.75% intravaginally daily for 5 days, or clindamycin cream 2% intravaginally at bedtime for 7 days. The FDA has approved metronidazole extended-release 750 mg once daily for 7 days and a single dose of clindamycin intravaginal cream for the treatment of bacterial vaginosis. However, limited data have been published comparing these regimens to established therapies. Alternatively, the CDC recommends either tinidazole 2 grams orally every day for 2 days, tinidazole 1 gram orally every day for 5 days, clindamycin 300 mg orally 2 times a day for 7 days, or clindamycin ovules 100 mg intravaginally once at bedtime for 3 days. Patients should be instructed to avoid consuming alcohol during treatment with metronidazole and for 72 hours afterward to avoid disulfiram-like reactions. Additionally, clindamycin cream is oil-based and may weaken latex condoms or diaphragms. Alternative products include probiotics which have been evaluated in non-pregnant women and have shown to improve cure rates and reduce the reoccurrence of bacterial vaginosis, although more studies are needed to establish their role in treatment. Bacterial vaginosis has been associated with preterm labor and premature delivery, and treatment is recommended for all symptomatic women. The CDC recommends metronidazole 250 mg orally 3 times daily for 7 days or 500 mg orally twice a day for 7 days, or clindamycin 300 mg orally twice daily for 7 days. Teratogenic data suggest that metronidazole is not harmful to the fetus. More recent data suggest that the use of intravaginal clindamycin cream is also safe to use for pregnant women. The next question reads, LOL. A 23-year-old woman purchases a non-prescription antifungal agent to relieve vaginal symptoms that she believes are caused by a vaginal yeast infection. LOL asks the pharmacist for assistance in the selection of an antifungal agent. What information should be obtained from LOL before a medication is recommended? The pharmacist should ask LOL if this is her first episode of vaginitis or whether she has experienced similar symptoms previously that have been diagnosed as a vaginal yeast infection and treated by a physician. The non-prescription antifungal agents are indicated for the treatment of vulvovaginal candidiasis in women who previously were diagnosed and treated by their physician. Additional questions that should be asked by the pharmacist include current symptoms, whether they are pregnant or not, other current medical conditions or medications, and allergies. Patients should be referred to a physician if any of the following are present. First episode of vulvovaginal candidiasis, has had more than 3 episodes of vulvovaginal candidiasis within the past 12 months, last episode was less than 2 months ago, is pregnant, is younger than 12, fever, lower abdominal, back, or shoulder pain, severe symptoms, or has a malodorous vaginal discharge. The next question reads, LOL has experienced 2 episodes of vaginal yeast infections with the most recent case occurring approximately 1 year ago. On both occasions she was diagnosed as having vulvovaginal candidiasis by her physician and responded to antifungal therapy. LOL currently describes vaginal and vulvar itching, vaginal soreness, and vulvar burning accompanied by a thick white vaginal discharge that has the consistency of cottage cheese. She has been unable to have sexual intercourse because of pain. These symptoms are similar to those she experienced with her previous vaginal yeast infections. LOL has no underlying major health problems. Her current medications include oral tetracycline for acne and ortho-tricycline for birth control. She has regular menstrual cycles and her last menstrual period ended 4 days ago. What clinical manifestations does LOL exhibit that are consistent with vulvovaginal candidiasis? What are the other common manifestations? LOL exhibits signs and symptoms associated with vulvovaginal candidiasis, i.e., vulvar and vaginal pruritus, vaginal soreness, vulvar burning, dyspareunia, and a thick white vaginal discharge that appears to be curd-like. Women may also have vaginal discharge which is usually described as non-odorous, highly viscous, and white in color that may vary in consistency from curd-like to watery. Vulvar erythema may also be present. The next question reads, how can vulvovaginal candidiasis be differentiated from other vaginal infections? Vulvovaginal candidiasis should be differentiated from other vaginal infections because a non-prescription antifungal agent could delay the appropriate treatment of other vaginal infections. The physical appearance of the vaginal discharge may be useful in predicting vulvovaginal candidiasis if it is a viscous, non-odorous, white, curd-like discharge and the patient has a normal vaginal pH, that is a pH below 4.5. The quantity of the discharge may be scanty to profuse. Some women with vulvovaginal candidiasis exhibit only vaginal erythema with minimal discharge or an increased amount of normal vaginal secretion. A vaginal discharge from a woman with signs and symptoms of vulvovaginal candidiasis should be examined for the microscopic presence of candida using a wet mount preparation with 10% potassium hydroxide or a gram stain of the vaginal discharge. The use of potassium hydroxide improves the visualization of yeast or pseudohyphae that are seen in approximately 70% of women diagnosed with vulvovaginal candidiasis. If the wet mount is negative, the patient's vaginal discharge should be cultured for candida in an appropriate growth medium. Isolation of candida without signs and symptoms should not result in treatment, because candida is part of normal vaginal flora in approximately 10% to 20% of women. It is the proliferation of Candida albicans or other yeasts that lead to vulvovaginitis symptoms. Non-prescription home screening tests are also available that measure pH levels within the vaginal epithelium, e.g., Vagisil Screening Kit and FemV, which are highly sensitive to pH changes but suffer from low specificity. The next question reads, do women such as LOL, who have an increased vaginal discharge and symptoms consistent with vulvovaginal candidiasis, necessarily have a vaginal infection? Although the possibility of vaginal infection must be addressed when a woman presents with an increased vaginal discharge with or without symptoms, other conditions are associated with an increased discharge. First, a physiologic vaginal discharge must be distinguished from a pathologic discharge. Physiologic discharges characteristically are non-odorous, white or clear, highly viscous or floccular, and acidic, pH approximately 4.5. Physiologic discharge may also become more profuse at midcycle secondary to increased cervical mucus or vaginal epithelial cells. Other conditions resulting in excessive vaginal discharge include retention of foreign bodies, e.g., tampons, and allergic reactions or contact dermatitis secondary to the use of vaginal spermicidal agents, soaps, deodorants, douches, vaginal lubricants, and condoms. Episodes of vulvovaginitis-like symptoms can be associated with frequent use of hot tubs, jacuzzi baths, or swimming pools that contain chemically treated water with high levels of chlorine. The next question reads: what specific groups of women are most susceptible to vulvovaginal candidiasis? Does LOL fit into any group at high risk for vulvovaginal candidiasis? Candida albicans colonization and symptomatic vulvovaginal candidiasis increases during pregnancy and with use of high estrogen-containing oral contraceptives. Estrogens increase binding affinity of vaginal epithelial cells to Candida albicans. Women with high glycogen concentrations, e.g., uncontrolled or poorly controlled diabetes mellitus, women with depressed cell-mediated immunity secondary to disease, e.g., cancer, HIV infection, and women receiving broad-spectrum antibiotics or immunosuppressive drugs, e.g., cytotoxic agents, corticosteroids, are also at risk for vulvovaginal candidiasis. Individual cases of vulvovaginal candidiasis, although not related to intercourse, may be related to orogenital sex. LOL is taking tetracycline, which may increase her risk for vulvovaginal candidiasis. Antibacterials increase the risk for Candida albicans overgrowth by suppressing the normal vaginal flora, e.g., lactobacilli, which normally protect against Candida albicans. LOL is also taking a low estrogen-containing oral contraceptive. However, low-dose oral contraceptives have not been consistently associated with an increased risk of vulvovaginal candidiasis. The use of diaphragms, vaginal sponges, and IUDs may also be risk factors for vulvovaginal candidiasis. Stress-induced vulvovaginal candidiasis and an increased incidence of vulvovaginal candidiasis before menstruation have been described. The cause of both is currently unknown. Although various dietary factors have been postulated as a cause of vaginal yeast overgrowth, the role of diet in the development of vulvovaginal candidiasis remains inconclusive. The next question reads: what vaginally administered therapy is effective for LOL's vulvovaginal candidiasis? LOL is an appropriate candidate for non-prescription therapy because she had previous vaginal yeast infections with symptoms similar to those she currently is experiencing, and her vulvovaginal candidiasis is uncomplicated, defined as sporadic disease with mild to moderate symptoms in an immunocompetent host. When a patient's vulvovaginal candidiasis appears complicated, defined as a recurrent infection, severe symptoms, non-Candida albicans infection, presence of uncontrolled diabetes, immunosuppression, and/or pregnancy, she should be referred to her medical practitioner. LOL should respond well to short-term topical azole therapy. In addition, LOL should ask her physician whether continuation of antibiotics is truly needed. If LOL had been evaluated by her physician, a prescription for single-dose oral fluconazole or 3-day intravaginal therapy might have been an option. The available azole antifungals are equally effective in treating vulvovaginal candidiasis with cure rates between 80% to 90% when a full course of therapy is completed. The medication used to treat LOL's vulvovaginal candidiasis should be selected based on response or failure to previous therapy, convenience, ease of use, length of therapy, dosage form, and cost. LOL should select a non-oil-based product if a latex condom or a diaphragm is used as a form of contraception. Next we will discuss other treatments for acute vulvovaginal candidiasis. Oral lactobacillus and lactobacillus-containing yogurt are advocated for the treatment of vulvovaginal candidiasis. However, evidence in support of this treatment is inconclusive. Boric acid 600 mg capsules inserted in the vagina at bedtime for 14 days is effective for the treatment of recurrent vulvovaginal candidiasis with eradication rates of 70%, but vaginal burning and irritation are common side effects and is poisonous if inadvertently ingested. Gentian violet preparations also have limited use in the treatment of candidiasis because they stain clothing and bed linens and cause local irritation and edema. The next question reads, how effective are orally administered azoles in the treatment of an acute vulvovaginal candidiasis infection such as the one LOL is experiencing? Fluconazole is the only oral antifungal agent currently recommended by the CDC for the treatment of acute vulvovaginal candidiasis. A single 150 mg oral dose of fluconazole is as effective as 3 to 6 day regimen of intravaginal clotrimazole. Although some women may prefer an orally administered drug to one that is administered intravaginally, the use for mild to moderate vulvovaginal candidiasis is of some concern because of the possibility for systemic adverse effects and drug-drug interactions. The next question reads, what adverse effects might LOL experience from intravaginally or orally administered azoles? When used intravaginally, azoles are associated with dose-dependent adverse reactions similar to symptoms women report from vulvovaginal candidiasis. Thus, it can be difficult to differentiate disease symptoms from adverse drug reactions. If the vaginal symptoms worsen after therapy is started, the patient should contact her healthcare provider. In addition, if symptoms have not improved within 3 days after initiation of therapy or continue past 7 days, the patient should contact her physician to rule out more severe disease or treatment of the wrong disease. Topical azole therapy has been associated with a variety of adverse drug reactions, including headaches, allergic contact dermatitis, vulvovaginal pruritus and irritation, dyspareunia, and general burning, soreness, and genital pain. Oral fluconazole has been associated with headaches, nausea, abdominal pain, diarrhea, dyspepsia, dizziness, taste perversion, angioedema, and rare cases of anaphylactic reactions. In addition, intravaginal miconazole has been reported to interact with warfarin, increasing the risk of bleeding and bruising. The next question reads, how should LOL be counseled about the use of a non-prescription vaginal antifungal product? The details of intravaginal administration should be reviewed with LOL, including instructions on how to clean the applicator. To minimize leakage and annoyance, LOL should apply the product at bedtime to increase retention in the vagina. She should be advised that the non-prescription vaginal antifungal creams and suppositories are oil-based and thus may weaken condoms or diaphragms, thereby reducing their effectiveness. LOL should be informed about the importance of completing a full course of therapy even if her symptoms subside beforehand and to continue her antifungal treatment through her menstrual period should it occur. In addition, LOL should be instructed to see her physician if her symptoms persist, if she experiences symptoms that signal a more serious problem, e.g., abdominal pain, fever, a foul-smelling or bloody vaginal discharge, and/or if another yeast infection occurs within 2 months. LOL also should be advised to avoid wearing tight-fitting, unventilated underwear, e.g., nylon panties or pantyhose, and tight-fitting jeans because a warm, moist environment can facilitate fungal growth. However, a study addressing risk factors for vulvovaginal candidiasis found no relation between type of underwear and the incidence of vulvovaginal candidiasis. In fact, many risk factors for vulvovaginal candidiasis are not consistently associated with this infection. LOL also could be alerted to the possible relation between candidiasis and swimming in a heavily chlorinated pool or frequent use of a jacuzzi or hot tub. The next question reads, how would management of LOL's vulvovaginal candidiasis differ if she had poorly controlled diabetes? Vulvovaginal candidiasis in a woman with uncontrolled diabetes is usually considered to be complicated vulvovaginal candidiasis. A diagnosis of complicated vulvovaginal candidiasis is also warranted when the vulvovaginal candidiasis is severe, recurrent, as defined, caused by non-Candida albicans species, or when vulvovaginal candidiasis occurs in an immunosuppressed, debilitated, or pregnant woman. The treatment of complicated vulvovaginal candidiasis varies depending on the underlying reason for the complication. Severe vulvovaginal candidiasis, e.g., extensive vulvar erythema, edema, excoriation, and fissures, may be treated with either a 7 to 14-day course of topical azoles or 2 oral doses of fluconazole 150 mg given 72 hours apart. Infection with non-Candida albicans species should be treated with a 7 to 14-day course of an oral or intravaginal azole. However, the optimal treatment is unknown. Oral fluconazole has poor activity against non-Candida albicans species and should not be used. Boric acid 600 mg capsules administered intravaginally once daily for 14 days can also be used, which has shown eradication rates of 70%. The next question reads, LOL experiences another case of vulvovaginal candidiasis 1 month later. So my question to you is, does she have recurrent vulvovaginal candidiasis? How should she be treated? Most women have only occasional episodes of vulvovaginal candidiasis, but approximately 5% experience recurrent vulvovaginal candidiasis infections defined as 4 or more episodes per year. To determine whether LOL has recurrent vulvovaginal candidiasis, a diagnosis of Candida needs to be confirmed by vaginal cultures. Then, underlying risk factors for vulvovaginal candidiasis, such as uncontrolled diabetes mellitus, consumption of excess sugars, IUD placement, and use of antibiotics, must be ruled out. Based on the timing of LOL's episodes and the absence of risk factors, LOL does not meet the definition for recurrent vulvovaginal candidiasis. If a patient meets the criteria for recurrent vulvovaginal candidiasis, an underlying cause of the problem may not be determined. In addition, the role of sexual transmission is not currently well understood. In most patients, the pathogenesis of recurrent vulvovaginal candidiasis cannot be determined. Treatment of recurrent C. albicans vulvovaginitis should include a prolonged, 7 to 14-day course of topical therapy or a 3-dose regimen of oral fluconazole 100, 150, or 200 mg administered every 3 days. A 6-month maintenance regimen should be initiated after remission has been achieved. Despite the efficacy of these regimens, discontinuation of therapy after 6 months can result in relapse in 30% to 50% of women. Azole-resistant strains of Candida albicans are rare, therefore, culture and sensitivity testing is not usually performed to help guide treatment before initiation. The next question reads, what teratogenic risks are associated with the use of azole preparations? Vaginal colonization with Candida and symptomatic vulvovaginal candidiasis are common during pregnancy. Asymptomatic colonization is not associated with increased maternal or fetal risks and need not be treated. However, symptomatic vulvovaginal candidiasis should be treated. Although doses of oral fluconazole used to treat vulvovaginal candidiasis have not been associated with increased fetal defects, higher doses may be teratogenic. Therefore, topical antifungal agents are preferred for treatment of vulvovaginal candidiasis in pregnant women. The CDC currently recommends a 7-day course of topical antifungal therapy for vulvovaginal candidiasis during pregnancy. However, a 3-day regimen with appropriate follow-up to assess efficacy has been shown to be effective in mild to moderate cases. Clotrimazole is also classified as a Category B drug for fetal risk, and the remaining vaginally administered azoles are designated as Category C. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 259.